Are you ready to advance your career in one of the most dynamic and impactful fields in healthcare? Welcome to the Cardiac Critical Care Fellowship, an entirely online program designed to fit your busy schedule, offering 3 comprehensive modules, each worth 30 credits. Learn from world-class clinicians and gain access to evidence-based content, cutting-edge research, and real-world case discussions in cardiac critical care. This program is tailored for self-driven learners who want to take control of their education and unlock their potential. Whether you're managing critically ill cardiac patients or looking to master ECMO, mechanical circulatory support, or perioperative care, this fellowship will empower you to excel. With flexible, interactive, case-based learning, you'll gain the skills needed to advance in this high-stakes field, all while earning certification to boost your career. Join us today and start your journey towards becoming a leader in cardiac critical care. Are you ready to make a difference?
Okay, over to you, Ali.
Good afternoon, good evening for everyone. Thank you for joining this today's webinar about shock rescue, the art and science of mechanical circulatory support. We'll be discussing current evidence and best practice in mechanical support for shock, including ECMO and other circulatory assist devices. Our respect faculty will share practical insights for managing these complex cases. So for starting, please join me in welcoming Dr. Gordan Samukovic, an esteemed cardiac surgeon, critical care consultant, and director of McGill University Adult ECMO Program, with advanced fellowship in critical care, echocardiography, heart failure, and ECMO from McGill and the University of Michigan. He is a leading expert in life-saving mechanical support. Today, he will share his insight on the cutting-edge use of ECMO and septic shock, a topic at the forefront of critical care innovation. Welcome, Dr. Gordan Samukovic.
Thank you so much, Dr. Ali, and thank you for this invitation to the organizing committee. Hello from Montreal. It's about noon time here, so I'm pleased to share this with you. So I'm just gonna share my slides, and hopefully everything works. And it looks like it does this time around. So I'm at McGill University, as Ali mentioned, and I run the ECMO and the cardiovascular ICU training program here. So thank you again for this invitation. I'm going to talk to you about a very interesting topic. And as you probably all know, random events tend to cluster. So at one point in time, you're going to have 5 or 6 of these patients in a row, and you're not going to know what to do with them. And then, 2 or 3 months will pass, and then you're not going to see another one for quite some time. So we're going to talk about when to use ECMO in septic shock, and I'll touch a bit on the pathophysiology of the septic shock itself and what happens in so-called septic cardiomyopathy. As much as I would like to encourage you not to use that term, this is not a cardiomyopathy. This is a sepsis-induced myocardial dysfunction. So there's no innate abnormality of the myocardium which would apply cardiomyopathy in these patients. This is something that is mediated by another process and not by the myocardium itself innately. I'll talk about septic shock and induction of ARDS. We'll talk about some literature and what we have out there, however limited it is. And we'll take it from there and talk about what we do, or we're at least attempting to do at McGill in terms of treating with mechanical support, whether it's ECMO or something else, those patients who are in cardiogenic shock, who are in a low perfusion state secondary to an element of sepsis. I'll try to touch a little bit on what the special consideration of ECMO itself are on when we're managing these patients, and take it from there. So I'm not going to dwell too much on this because I'm sure you've heard this a million times, but when it comes to the septic shock and this cascade of events that happen from the immune system activation, cytokine release, inflammatory media flooding, and then leading to endothelial disruption, increased permeability, swelling, edema, the shifts of ions, and so on, eventually leading to circulatory changes, hypoxia at the tisular and mitochondrial level, and then eventually leading to myocardial function suppression. So when we look at septic shock and ARDS, ARDS complicates almost a half of the septic shock cases, even when the primary disease is not that of the respiratory system. And, you know, a lot of times we go and see these cases and they are potentials for VV ECMO rather than VA ECMO. But some of them, as you've encountered, due to the changes of the vasculatory bed and in the lung itself, can require right ventricular circulatory support or ECMO support simply due to RV dysfunction that happens in these cases. So left ventricular function alike happens in cases of septic shock. Now this, you know, is variable in presentation. It's probably 20 to 45%, depending on the type of shock that the patient is in. The characteristic of this particular entity, clinical entity, is the very high mortality that's associated with it. However, those patients who pulled through tend to reverse their left ventricular function quite nicely, usually at about a week's time, and they tend to recover quite nicely. This is, as I mentioned, totally a different entity from myocardial dysfunction that comes from other reasons, even if it's primary myocarditis or ischemic heart disease and things like that, and it should be treated as such. So even if we look at some of the very early studies, this was published in 1985, there was this whole notion or an idea of circulating substances in patients who are in septic shock that eventually lead to myocardial depression. And in terms of these substances, people were trying to identify endo and exotoxins, TNF factors, nitric oxides, interleukins, and so on and so on. So people looked at those who are in septic shock, who have sort of normal myocardial function or close to normal myocardial function, and those who don't. And there's been a mission over the years to sort of try to correlate these patients with the outcomes, meaning in the cohorts of patients who have a septic shock, they would identify the ones with low flow states versus the ones with a sort of normalish flow state and see whether there's associated mortality with it. Then people try to separate and see whether there is a differential when we're talking about the right ventricular dysfunction and its impact on mortality, looking at the right ventricular dysfunction occurring to almost in half of these patients, and then how that would affect a left ventricular filling, ventricular interdependence, and where would that lead clinically. And when we talk about myocardial dysfunction in the context of sepsis, we're looking at mortality close to 80%. And as I mentioned, generally, if the patients pull through, they tend to reverse this quite nicely and come back in a follow-up echocardiography at 6 to 12 weeks back to their baseline state. So how do they present? They present like any other. It's usually a distributive shock at the beginning, which might or might not be associated with an element of the right ventricular failure that eventually leads to cardiogenic shock. And this cardiogenic shock might actually be induced due to the myocardial insult itself, due to hypoxemic insult itself, or infiltration by whatever organism it's happening, or it's simply mediated by the immune response. It can be a combination of right and left, or simply just left ventricular dysfunction, which we've seen more often than we thought. So when we looked at some of this early data, there was always a question on when we segregate the patients who have septic shock and those who survive and don't survive, and try to correlate their perfusion state in terms of the cardiac index or whatever it was used to measure it at that time, whether it was Swan-Ganz or however, to see whether there's a correlation of patient populations with low cardiac index with mortality, with a higher cardiac index and mortality, and see whether we can identify a subgroup of these patients who would benefit from increasing their circulatory potential and increasing their total flow by augmenting it either through ventricular support devices or VA ECMO itself. Now, my criticism of some of these studies is this focus on LVEF. I think in a lot of septic cases, LVEF is quite a useless parameter. I tend to rely more on the measures of flow and stroke volume index, whether you're obtaining it, or stroke volume variation, whether you're obtaining it by Swan-Ganz / PA catheter, or whether you're using some sort of arterial technology to obtain the same data. LVEF is, one of those dangerous parameters that you can rely on, especially in the context of RV dysfunction or limitation, and can mislead you in terms of quantifying the flow in these patients. So if we look at this particular one, again, my criticism is that they looked at left ventricular ejection fraction rather than the volume itself primarily, and tried to correlate it with the death. They looked at the end ventricular end diastolic volume index and compared it to the LVEF, and then analyzed the subgroup of patients who had low, what they assumed was the low ventricular function or poor cardiac output, and found that half of the non-survivors who developed a decrease in cardiac index with no change in ejection fraction. This particular group was different from the non-survivors who died in a cardiogenic shock-like state. So we needed to move on and sort of look at whether we can target these populations of patients who were in low cardiac output state in a septic shock milieu, and see whether we can do something about this. Notion here being that if the patient is in a normal flow state, meaning patient is in septic shock, vasodilatory type of shock, but the cardiac index or cardiac output is measured in physiologic or supraphysiologic levels, then the augmentation of cardiac output to meet the flow needs is probably impossible using the current technology that we have, unless you're using standard paracorporeal ventricular assist devices that are implanted in the operating room, which nobody does, because the mortality associated with that is through the roof. So the question really is, how do we identify the patients who would benefit from mechanical circulatory support or augmentation of flow in the septic state, whether this is the patient group and what level of myocardial dysfunction they should have in order to be targeted properly to benefit from augmenting their circulatory potential. So we extrapolated some of this data from the pediatric side and said, well, it seems that in kids, because their flows are generally low compared to adults, that if we bring these flows to higher and supraphysiologic states, there was a higher chance of survival. This was published in 2020. If we extrapolate that to the adult population, then we should try to identify the patients who are in low flow state in the context of septic shock, identify what is the threshold for this low flow state to be an impacting factor on the survival, and then try to correct that to the normal physiologic state. If you remember, a lot of studies on cardiogenic shock from the 1980s, when we thought, the more is better, and we tried to pump patients up with epinephrine, dobutamine, and God knows what, in order to achieve cardiac indices of 4, 5, and 6, because we thought if normal is good, then supranormal must be better. we've miserably failed at this. So the idea was to find that balance of augmenting the flow, but just enough to meet the metabolic needs, which were identified to be whatever they are for each individual patient. So I'm going to brush through some of this just to illustrate some of the points. There is this study from Korea that looked at some patients that they did 52 patients over a period of 5 years. Who were supported with ECMO in the context of refractory septic shock. And we can see sort of what all of these patients had VA. 21 of them were ECPR, and you can see that the survival rate was just catastrophic of about 15%. And that seems to be the theme for the rest of these studies that I'm going to show you. This one is, and I always, hope that neither Mathieu or Nicolas are not in the audience when I say this, but it's too good to be true a little bit with the, again, this is not a very large study, obviously, 14 patients with all VA with some conversion rate of about 30%. Where the about 80% of them actually survived, 85% as a matter of fact, with 10 patients of 15 leaving the hospital neurologically intact. Again, I will explore this later with the data from this particular group on a larger scale. Another study from Far East looking again at survival of patients in septic shock who were cannulated, all VA patients, only 20% survival again. There were 7 patients with ECPR, I think none of whom survived. That seems to be the theme of this particular thing. If we look at this study, this is a 2-to-1 study of VA to VV patients with similar characteristics. A very large group, and when we looked at the survival rate of about 30% of the VA patients, and they had only 8 survivals of the ECPR patients of almost 30 of them. So we're kind of trying to establishing a trend here. This is a very small study with only 8 patients, 4 of whom survived. This particular one that also came from Korea illustrates the point that we probably shouldn't be doing ECPR on patients who are in myocardial arrest from a septic state. And so on and so on. So I'm going to obviously, if you wish, I will send all of these to any of the participants to review on your own. But the theme really is that of first, the data is very sparse. Second, it really looks like a VA modality tends to predominate in these patients who are hemodynamically compromised, even though some centers tend to correct hypoxemia first before addressing the circulatory part, and the survival ranging anywhere between 15% to 70 somewhat percent, depending on the patient selection and so on and so. The message again being that ECPR probably not the right thing to do because of very, very low discharge number of patients who are discharged to home. So I want to focus a little bit on this study. This came again from our colleagues in France. This was presented by Mathieu Schmidt at the ELSO meeting, and they really focused on this. They did some propensity matching and looked at their patients who, from a similar demographic, a similar profile of illness, who ended up supported with VA ECMO versus those who did not. Now, in terms of the patient characteristics and whatnot, you can see them here. What is quite impressive is the survival rate of 60% of the ECMO group. So, what they are arguing specifically is that in the set of patients with cardiogenic shock, who have a myocardial dysfunction and who have an identifiably low perfusion state, meaning that the flow is inadequate for the metabolic demands of the patient, at which point in time do we trigger and say, where do we go from here, and can we augment circulatory potential of these patients in order to reverse this mortality that is 75% in the non-supported patients to 40% mortality in the patients who ended up receiving VA ECMO support. So when we look at these things and when they follow their patients who ended up on ECMO and whatnot and followed up their ejection fractions, again, as much as I'm not a big fan of this, they looked at the recovery itself as well, meaning if the patient was supported with VA ECMO, went through, survived, X number of months or X number of days later, what happens to the ejection fraction? And astonishingly, they found that most of those who survived, who were supported adequately, recovered their left ventricular ejection fraction itself, and assumingly also the stroke volume at the follow-up study. So the whole idea is, what is the patient population? How do we identify the group that will benefit within this cohort of patients who are aseptic? And if we identify them, what is the correct modality of ECMO to employ immediately? What are the triggers? And then on top of it, what configurations do we go through as the patient progresses during their illness path? Again, I'm not advocating at all ECPR in these cases. I think these patients should be identified earlier and supported if they fall into this category, and then the configurations can be changed as they progress. So what do we do? At McGill, I am going to credit my fellow Fazal Al-Yahya working very hard on this and trying to establish a set of guidelines based on what we have learned from these, however limited studies there are, and from the French group. So we obviously start with treating our patients for sepsis the way we treat them routinely, with fluids, antibiotics, et cetera, et cetera, et cetera. Those who are identified with to have developed only ARDS, we treat them according to the guidelines for ventilatory protection and so on and so on. If they have isolated RV dysfunction that is associated with ARDS, we tend to use the right ventricular support device plus or minus the oxygenator, depending on what's happening. If there is LV failure, LV dysfunction, and on echocardiography, the LVEF is less than 35%, or the cardiac index by PA catheter is less than 3, or the lactate is rising to above 4 with high vasoactive inotrope score, we tend to employ VA ECMO to augment these patients. In absence of these criteria, meaning if the cardiac index is normal or above 3, if the left ventricular function is above 40% and above, we tend not to pursue ECMO cannulation, because based on the French data, this is the group that does not benefit from VA ECMO in these patients. If we're obviously dealing with ARDS as well as left ventricular function, we tend to use VVA configuration as needed. Only once have we done the RVAD with oxygenator plus the LVAD, percutaneous LVAD, for these cases. A good option if you have this available at your option. So again, how do we go about it? We have to select these patients very carefully. We have to be aware of the course of the disease itself. What kind of a shock are we dealing with? Let's make sure that we're putting patients on ECMO, the ones who are appropriately chosen for that, and so on and so on. And what do we run into when these patients are managed? What are the challenges that come with sepsis itself? What is the importance of the quality of oxygenation, the consideration about Harlequin syndromes and things like that, and so on and so on. We always obviously we assess our patients pre-insertion. We evaluate their demand. We lower the oxygen consumption if we can, and so on and so on. We tend to obviously cannulate with cannulae that are large enough to assure adequate flow to support the patient's needs, and change configurations or add oxygenation catheters if needed to address this. Anticoagulation can be challenging in sepsis. These patients tend to be bleeding yet be procoagulant, and these can be very difficult to manage. So this is something that they have to be aware of, and maybe employ multiple measures of anticoagulation state to see to determine the best way of anticoagulating. Antibiotic therapy is challenging. We wrote 2 systematic reviews on this, the importance of pharmacokinetics and pharmacodynamics of these patients and dosing this properly. Years ago, I had a young man here died because we inadequately dosed an antifungal. It was all sequestered into the membrane, and he ended up dying without us even knowing why. It was inadequate antimicrobial therapy. Since then, we basically studied everything from antibiotics to stem cells to chemotherapy to see how they interact with the membrane itself, and have learned that you have to be very careful. So this is pretty much all I wanted to talk about. I don't want to overwhelm you too much on what happens here. It is a very complicated topic, and I thank you again for the invitation. I'd like to finish this by dedicating this talk to healthcare workers elsewhere in the world who are unable to provide the medical care the way we do, but do it with passion to the best of their ability, every day facing things that we don't face ourselves as we take care of our patients. Thank you very much for the invitation, and thank you for listening to this talk.
Thank you so much, Gordon, for this great presentation, and very informative about how to propose mechanically circulatory support, and especially ECMO in septic shock. We have some questions from the audience. I think I will select 1 or 2 from all we have. We have a lot of people from all over the world. So what are the complications that you are expecting when you put a patient on ECMO in your practice? What have you seen, and what you have to expect?
Well, it's I think one of the things that you might face sort of early is inadequate flow. You know, that you're still seeing that, for example, lactate is rising because you're providing, let's say, if we look at cardio help, usually you can boost the flow up to 5.5 liters and you're limited there. And as much as we all know that sometimes the patients in sepsis and liver failure and whatnot, they require circulatory flows of above 8 liters. So you just have to satisfy yourself that this is a circulatory support. It's not a circulatory replacement. So you have to understand that, you know, you will be able to provide the support to some degree. The rest is going to depend on the patient's physiology and what else it is that you're doing to them. CRRT, antibiotics, inotropic support, and so on and so on. In terms of what things that we face sort of daily is always infected cannula and the potential for infection of the cannula. We're putting cannulae into patients who are septic, who are most of the time bacteremic, fungemic, and so on and so on. So we're now introducing another surface that potentially bombards the milieu of the patient with a different set of inflammatory factors. And then we manage the bacteremia and whatnot in the patient, but the cannulae are staying infected. Now we're removing cannulae and replacing them with new cannulae. We've done all of this, and the more you do of these, the more you sort of recognize these challenges that are so weird. You know, patients who are bleeding from their eyes, yet the circuit is clotting because they're procoagulant, you know, from the septic state. You know, they're in DIC, but they're clotting. It's all of these things you see as you move on.
Thank you so
Is there
much.
anything specific that the author of the question asked?
No, just complication in general. Another question, which patient you will not put, because you know the timing is sometimes difficult to know when we have to do, so you put some criteria. But some patients, they come to emergency, they are young and they are already in multi-organ dysfunction. What you do, you have low cardiac index, patient is already on acute kidney failure, he has already liver enzyme shooting up. What's your take message from that? What you would like to select, how you would like to select a patient?
So the multi-organ failure doesn't scare me in these patients, and in particular, young especially, because we have a reasonable data from our institution showing that upon reversibility of flow, meaning that when you bring your patient to an adequate flow, the multi-organ failure, unless it's way too advanced, which is sort of not what you're describing to me, will reverse. In particular, we're looking at normalization of lactate with about 12 to 24 hours, normalization of creatinine within a 24 to 48 hours. We're looking at normalization of liver function enzymes after 72 hours, the peak being at 72 hours, and so on and so on. So once you are happy that you have reversed the shock, meaning, and when I say the shock, I mean the circulatory component of the shock, I think the multi-organ involvement shouldn't scare you unless you're too late. If these patients should be put on the moment you identify a compromised circulatory state. There's no time to be like, oh, the patient's the patient is in shock. Let's try for 2 days with dobutamine, epinephrine, and so on. You've lost that battle. If the patient comes in septic and they have myocardial dysfunction that leads to decreased flow, I think they should go on. And it should be a little bit black and white to streamline the therapy.
Okay, thank you. I think that's clear. Last question. How you do you use some techniques, blood purification techniques, in the same times or never?
I haven't, and I haven't been convinced with the data yet that this is something that we should do. I know of the resins and I know of all of these new things that we have out there. I have to be convinced. I know some of my colleagues have, and they've had variable results. And I'm very open to consider this when we have some data that this works. But so far at McGill, we haven't used it.
Okay, thank you. So I think we'll close this lecture and we'll let our colleagues to present the program of the WICCEM.
Perfect. Thank you so much. I'm just going to quickly introduce the World Institute of Critical Care and Emergency Medicine. I'm here between the two talks. I'll be quite brief. We're all looking forward to the next talk. So at the World Institute of Critical Care and Emergency Medicine, we've established an online cardiac critical care fellowship program, a purely online educational program that spans a whole year and covers 3 modules. The first module is Foundations of Critical Care, where we discuss the really essentials and need to know for any cardiac intensivists with regard to cardiovascular anatomy, pathophysiology, cardiovascular pharmacology, hemodynamic monitoring. We have 2 weeks of managing critical care emergencies in cardiovascular medicine, things like acute valvular dysfunction, ACS, acute aortic dissection. And then we have a bit of a focus on critical care ultrasound, and specifically transesophageal echocardiography, which tends to be heavily used in most cardiac critical cares. And then we move on to the next module. The next module is a perioperative cardiac care module, and that really is the bulk of the fellowship. Most of us as cardiac intensivists take care of patients after cardiac surgeries, and so we go through the basic intra and post-op care aspects. Some of the post-op complications that we see, including things like vasoplegia, low cardiac output syndrome, RV failure, tamponade, bleeding, and management of specific cases, like management of post-op aortic dissections, management of post-op valve replacements. And so this module is a module that I think most of our cardiac intensive care colleagues will be very interested in, especially those who are in training. The third module is the one that talks about mechanical circulatory support. And so in this third module, we cover ECMO with a lot of focus on VA ECMO, but we also have a week dedicated to VV ECMO. And then we go through mechanical circulatory support aspects of that we need to know as intensivists, how to manage a balloon pump, an Impella, a durable left ventricular assist device, RVADs. So all of these we cover in Module 3. So it's a comprehensive one-year program that really covers all you need to know as a cardiac intensive care physician. I think it's an investment in your career. At the World Institute of Critical Care and Emergency Medicine, we don't believe that learning is a monologue. It's not all just lectures. There are actually interactive webinars. There will be question and answer sessions. There will be MCQs to test your knowledge. There will be journal clubs. And so it is an ongoing one-year fellowship or an online educational fellowship where you get to basically build up your knowledge and invest in your long-term career. If you're going through an exam, then it helps you prepare for that exam. A very comprehensive program that we offer at the World Institute of Critical Care and Emergency Medicine. I would encourage you to visit our homepage. Just go on wiccm.org and then look for the Cardiac Critical Care Fellowship Program and explore our speakers, explore our board, explore our curriculum, and let us know what you think. And with that, I will pass it on.
First of all, I would like to welcome you all to this great webinar. I really enjoyed the talk by Dr. Gordon, and I'm really amazed by what you are doing and saving life. And I think everybody should be, as Gordon said, black and white for the treatment of such critical patient. No time to lose. If you want to build a program, you have really to be aggressive. Without further ado, I would like to introduce the next speaker, Dr. Aus Al-Herbesh. He is a critical cardiac intensivist with a great experience and echocardiography and ultrasound, critical care ultrasound. He's a program director of the CVICU at the University of Alberta, Edmonton. Two great speakers. I did my training at McGill, and they did not accept me at Alberta. So let's see what I'm gonna do. The floor is yours, Aus.
Thank you very much, Dr. Weil, for the kind introduction. I think that was probably the biggest mistake Alberta had done in their history.
So I left, after McGill, I left to the University of Chicago, where I did my congenital structure interview. Great experience, and really, really full respect to Canada and USA for training us. We love them all.
That's great. Thank you so much. So from septic shock, we're going to switch gears now to cardiogenic shock. And I'm going to talk about how to pick your device in cardiogenic shock. Okay, so I have no disclosures or conflict of interest in this. So we definitely are living the plethora of devices era at this point of time with multiple devices available under your leadership and discretion for cardiogenic shock. So we'll try to see what device offers what advantages and what disadvantages do they have. So I like to simplify things, and I like to teach ECMO a lot. So when I teach the fellows and the trainees, I always tell them, try to simplify it to this. When you're scratching your head in front of a cardiogenic shock, whether it's in the cath lab, in the operating room, or in the CCU or ICU, think about this. Are you going to support the heart? Are you going to need to support the lung, or the heart and lung together? Number one. Number two, are you going to need left support, LV support only, solo LV, or solo RV, or are you going to need left and right support? Number three, can you go percutaneous, or does it have to be surgical? Think about peripheral vascular disease. Think about access. Think about the auxiliary option, which is becoming more and more used these days. And then does it have to be central? It's clear that if you are in OR and it's a post-cardiotomy shock, it's going to be more surgical. If you're in the cath lab, it's more likely to be percutaneous. If you're in ICU, it could be either. Most likely percutaneous, but you have to think about that. Then is the device you're going to use going to be, is it going to be temporary or it's going to be durable? Is it going to be a destination or it's going to be a bridge? So the objectives of this talk, we're gonna first talk about who does not get a device. That's more important than who will get a device. So who is excluded from the get-go? And I'm gonna simplify it as much as I could. And then who else does not get a device? Because after you exclude people in the beginning, you're gonna exclude more people as the process keeps going, and I will show you how and why. And then what device, and I'm gonna spend most of the time here. As I said, there is a plethora of devices now, so we're gonna talk about what device should be used, and then what other devices, because guess what? When you implement a device, that's not the end of the story. Most of the time, you're gonna need more devices down the road until you reach your destination. So before we dig into this, first of all, we have to acknowledge that we have a great literature gap, and we need more studies. So what's the reason? We had a couple of good studies, but most of them were done on acute myocardial infarction cardiogenic shock, and less was done on heart failure cardiogenic shock or non-AMI cardiogenic shock. Also, we have not tackled most of the details about when, how, and whom. So the timing of implementing the device, I think we have glitches. We know a little bit about that now, but we don't have the details. Device-specific benefits, what are the physiologic goals, the MAP target, the mixed venous target, the hemoglobin target after implementing those devices, the phenotypes of shock. Now, is heart failure different than acute MI? Is the myocarditis different? So the phenotypes, LV plus RV, LV alone, phenotypes of cardiogenic shock, and then the selection. Do we have to narrow our selection criteria, or do we have to widen our selection criteria? So there are a lot of gaps. So what we know is that to choose a device and to decide about going into a device, you need a shock team approach. And a shock team approach means at least, usually it's 4 to 5 attendings or consultants, including a heart failure specialist, an intensivist, a cardiac surgeon, and an interventional cardiologist, and it could be more people. Could be LVAD specialist, there could be more people. So who doesn't get a device? So again, I like simplicity. I like to simplify it for my trainees. So think about those 3 paradigms. Okay, number 1, age and frailty. Anybody above age 75 should not get a device. Okay, in some institutes and some centers, that the number goes down to 65, okay, or 70. So it is tailored to the center experience. But elderly people should not get a device. And frail people, those with old biological age, frailties, not just the real age, but biological age, should not get a device. Okay, number 2, comorbidities and end-stage diseases. If you have someone with an end-stage disease that you cannot resolve by your device implementation, then end-stage, for example, liver cirrhosis or malignancy with metastasis, then you should not, those people should be excluded from having a device. The third paradigm is the etiology and exit strategy. So what's going on? You have to have at least an idea about what's the cause of this shock, and is it likely to recover, or is the patient a candidate for destination therapies like heart transplant or HeartMate 3? So what is the etiology and what is the exit strategy? If you have no exit strategy, you should not implement a device. You have to have an exit strategy. Okay. So after you go through that exercise, then you have, then there will be more people who might not get a device for anatomical reasons. So nobody should get an ECMO or an Impella or a device before they get an echocardiography. So I call this the echo excluding criteria. So you have to have an echocardiogram. And why do I have to have an echo? Well, number 1, because not all cardiogenic shocks have low cardiac output. Or in other words, you could have a primary cardiac event with hyperdynamic ventricles and a high stroke volume. And guess what? This patient population are the hardest to support on ECMO because you cannot flow high enough. So you have to have an echo to show that there is ventricular dysfunction, whether it's LV or biventricular RV, and that the stroke volume is low. as we heard from Dr. Gordon's lecture before this. Even if it's septic shock, there has to be a low cardiac output so you can support your patient. If the cardiac output is already high, if it's 8 liters, you will not be able to support that patient. And then you have to check for the anatomical contraindications, which are very well known. Severe AI, aortic dissection are contraindications for any type of mechanical circulatory support, unless you can do something about it, unless you can fix the AI, for example, surgically. So if you have a mechanical aortic valve or LV thrombus, Impella might not be implemented, might be contraindicated. TAVI and Impella, there is back and forth regarding that. So you have to check your aortic valve. You have to check for anatomical contraindications for your MCS implementation. Okay, echo as well will be a cornerstone for your device selection. How is that? Now, echo will tell you if it's a solo LV or biventricular problem or a solo RV, and that's cornerstone in deciding what device you should use. Okay, who else does not get a device after your selection criteria, after your echo criteria? So timing matters so much. You don't want to implement your device too early where it's not needed to begin with, and you don't want to do it too late where it's going to lead to death even after implementation. And I like this parachute metaphor that was published in Circulation a couple of years ago. So you have to inflate your parachute in the right time. So you don't want to do it before pharmacologic therapy had proven to fail, and you don't want to do it after irreversible end organ injury is established. So as Dr. Gordon had said in the lecture before, most multi-organ failures, if they are early, they're forgiving. They will be reversible. But if you wait too long, if you wait until the lactate is 20 and the liver enzymes in the 1,000, the INR is high, you're not going to be able to reverse that patient. So the liver will continue to be in trouble after implementation. So you want to do it when it's the right time. Now, most of the patients you will be cannulating will be in SCI D. Fewer people will be in SCI E, and even fewer people will be in SCI C, because SCI C you'll be able to support them pharmacologically for the most part, and SCI E, where there is CPR and there must be post-ROSC, and they have very high mortality even with implementation of devices. So the largest 3 trials we had so far in cardiogenic shock are the SHOCK 2 trial, which is a very old trial now, more than, I don't know, maybe 15 years, and the ACLS shock trial, which was ECMO AMI trial, a negative trial. And most recently, we had the DANGER trial, which was positive, but with some very, very, very restrictive inclusion criteria and enrollment over 10 years. So people have some conservative opinions about it. So DANGER trial was the last one. It was AMI Impella trial, and it was a positive trial. So before we dig into the type of devices, you have to understand the differences or the physiological advantages and disadvantages of those devices. A balloon pump, which is in the top here, as you guys see, the biggest advantage of balloon pump is augmenting coronary perfusion. Okay, it does decrease the afterload a little bit, as you see on this stroke work diagram, and it does improve the cardiac output very slightly, but it won't provide a lot of flow for you. If you need to double flow of the patient, or if you need to triple the flow, balloon pump should not be your choice. Okay, so coronary augmentation is the biggest advantage. It doesn't change the stroke work diagram too much. Impella, on the other hand, as you see here on the second diagram, does decrease the preload quite a bit, and it does not alter the afterload that much. So it does decrease stroke work by decreasing the afterload of the left ventricle. While ECMO, it's probably the best in deflating the heart and decreasing preload. However, the disadvantage of ECMO is that there is an increased afterload because you provide the blood retrograde, because you flow retrograde against the heart. So there is an increase in the afterload that the heart sees. So if you don't decompress the heart, or if the heart is not ejecting, guess what? You're going to increase LVEDP, and you're going to cause heart failure and pulmonary edema because of ECMO. So when you are in front of a cardiogenic shock patients scratching your head, think about those 3 paradigms. What did the echo tell me? the clinical picture and the logistics. And the logistics is very important. I always tell my trainees, the logistics is probably the most important. So in the echo, so you have to know, is it a single ventricle or biventricular? Is the RV down? You have to know about the aortic valve function. As we said, there are contraindications if there is severe AI, or if there is, for example, a mechanical aortic valve with impella. You have to know if there is mechanical complication. Is there severe MR, PAP muscle rupture, VST, because those people should be supported differently. So you have to have those echo information. Number two, the clinical situation. Is the lung okay, or do we need lung support? What is the arrhythmia burden? Are we having AFib storms and VT storms? Because those people should be supported differently. The bleeding risk and the vascular access. Are they likely to bleed? Is it a PE that received TPA already? Or MI that received altiplase, where central ECMO, for example, will be a very high bleeding risk. So they have to go percutaneous, or you have to do impella. And then the vascular access, can I go femoral, or do I have to go central or axillary? So you have to think about those clinical points before you decide which device. Now, the logistics, which I have said, it's the most important thing. So you have to know about the urgency, which sky type I'm dealing with. Is it C, D, or E? Do we have to go right now? Can we wait? Can we go from the cath lab to OR? Can we go from OR to the cath lab? Can we go from ICU somewhere else? So you have to think about the urgency of cannulating. And number two, the setting. Yeah, so where are we? And what devices is closest to us, and how fast can we implement that? So logistics is maturity. You have to be mature when you make that decision. And then you have to have a very good understanding and knowledge about the differences between those devices, the differences in complications, and the differences in the pathophysiology provided, the advantages and disadvantages, which I have touched upon recently. Okay, now this is the most important part of the topic. So let's try to break it down and have some framework about what device should I go to. So the biggest two devices nowadays that are available will be either Impella or VA ECMO. Okay, so who should go to VA ECMO? Or as I said, as I always say, should crash on VA ECMO. Who should crash on VA ECMO? So when you have an extremis shock, you are crash and burn, then it's ECMO. You shouldn't play around with Impella or any other, or balloon pump or any other devices. If it's extremis, it's ECMO. If you have a CPR or post-ROSC, that's an ECMO. Okay, so you don't want to play around with that patient as well. If you have oxygenation problems, if you have lung problems, it's ECMO as well. Okay, because you need an oxygenator. Impella is not going to be helping here. If you have high burden of arrhythmias, AFib, VT, or whatever it is, it's also ECMO. You need full support. Because the RV is going to fail. If you support the LV alone, the RV will fail with arrhythmias. So then you need a full ECMO support. If you have an RV problem, clearly enough, you're going to also go on ECMO. So RV, oxygen, arrhythmias, extremis, CPR. Remember that. Those 5 situations, you have to crash on VA ECMO. Okay, if you are in the OR and cannot say, or what we call post-cardiotomy cardiogenic shock, then most likely you're going to also come on VA ECMO centrally, with usually a vent through the pulmonary veins. Okay. So who then should get an Impella, or who then should have an Impella device, not an ECMO? So if you're in the cath lab, having an acute myocardial infarction, cardiogenic shock, after Danger study, we feel stronger about that. Having a solo LV problem, so it's an anterior MI with a solo LV problem. The RV is fine because it's not inferior. The RV, you looked at it on echo and it's fine. And you're in Sky D. You're sliding on your pressors or inotropes. That patient should get an Impella in the cath lab. So an Impella CP in the cath lab, because they will continue to have some cardiac output, and Impella will just augment their cardiac output. As you guys know, Impella CP can provide 3.5 liters. If you go around 4 liters and above, then you start to have hemolysis. You're not going to be able to flow. So that patient who needs partial augmentation of flow and has a solo LV problem and is still awake, did not have CPR yet, should get an Impella device in the cath lab. Okay, I hope that is clear. Now, okay, who is okay to have a balloon pump? Who is okay to have a balloon pump? As you guys know, the literature had been harsh on balloon pumps. Shock 2 trials a long time ago, and more recently, the ALT Shock 2 trial for heart failure cardiogenic shock is a negative trial. So balloon pumps still have a role, and mostly because of the center experience. Many centers around the world don't have a lot of experience with Impella yet, okay? So if you're in the night and a patient is admitted with heart failure cardiogenic shock, not MI. The MI balloon pump literature is clearly no-go. So if you have a heart failure cardiogenic shock, somebody with cardiomyopathy is admitted, he's sliding on inotropes and he's failing, and your center experience does not allow further therapies to be done at that moment. So if you are SCI-C sliding to D, not crashing where you need ECMO, but SCI-C sliding to D, heart failure cardiogenic shock, with a center experience that doesn't allow Impella implementation, then it will be okay to put a balloon pump as a bridge to something. So a balloon pump will be acceptable in that case. Okay. So that was the most important part of my talk. So what then? So remember, when you put a device, that's not the end of the story. Sometimes you need more devices. So let's say you crashed on VA ECMO because of the reasons we've mentioned before, extremis shock or whatever, and your patient is not ejecting. So the LV is not ejecting. So it's met with a huge afterload because of the retrograde ECMO flow, and you're going to run into high LV-EDP and pulmonary edema and many other complications. You will need to add a vent. So guess what? Most centers now add an Impella as a vent for that kind of patient. So you have ended now on ECMO Impella, okay? And that's becoming more and more common. Now, let's say that you did the other way around. So the other example, you started with Impella because of the reasons we mentioned before: cath lab, acute MI, SCI-D, solo LV. So you put an Impella and the flow is not enough. You're flowing 3.8 liters and the patient is becoming more distributive or whatever, so you need higher flow, lactate is not clearing, then you're gonna go on VA ECMO. And you're gonna leave your Impella and you're gonna use your Impella as a vent. So you've ended up now on Impella and ECMO. So yeah, you start with a device and then you add the second device, as we talked about. So if you start with a balloon pump for the heart failure cardiac shock who's sliding from C to D, then that patient cannot wait forever for a heart transplant or for HeartMate 3 LVAD. Then you should go on either auxiliary VA ECMO. Why auxiliary VA ECMO? Because you need to mobilize that patient so that he continues to be eligible for destination therapies, or CentriMag LVAD, or in some centers Berlin Heart, to be able to as well mobilize your patient and so that he stays eligible for destination therapies. So from a balloon pump, you're going to move to a support that allows mobilization. Okay, so we talked a lot about SCI-D, and then SCI-E we said should get an ECMO. So how about SCI-C heart failure? So SCI-C, for the most part, you can support pharmacologically. So, you know, dibutramine, milrinone, and a little bit of vasopressin. So you have a good map and you have enough. So most of those people need, by the way, a Swan-Ganz, a PA catheter nowadays, and there is strong evidence for that. So then you can titrate to effect and you have good perfusion, and then you bridge from pharmacologic to destination, whether it's a heart transplant, HeartMate 3, or whatever it is. Sometimes you will need a bridge between pharmacologic therapy and destination. If the patient is failing in front of your eyes on inotropes, then you might need, as we said, a CentriMag VAD or an auxiliary VA ECMO until you get to your destination. So what are the destination therapies? There is only 3 destination therapies. Recovery, so your heart recovers, for example, myocarditis, MI that had been revascularized. So you decannulate your ECMO or you decannulate your Impella, and then you're fine. So recovery is 1. 2, durable LVAD, HeartMate 3 in most cases, where a patient can go home on a HeartMate 3 or a heart transplant. So those are the 3 destination therapies that you have to always think about: recovery, durable LVAD, or a heart transplant. So how to get to my destination if I'm on ECMO or Impella? You can go straight, or you might need a bridge in the middle. So what bridge in the middle you can apply? So So if you are on VA ECMO, remember that you cannot cross the 2 weeks margin because the risk of stroke and bleeding and everything increases so much. After 1 week, I start to be anxious. At 10 days, I become really anxious. So then you have to go through this exercise. If the lung remains a problem, you might have to go from VA to VV, or from VA to VAV if there is only partial cardiac recovery, not full. Okay, so you can support the heart and the lung together. If your heart remains a problem, but the lungs had recovered, and you are at the 2-week mark, you can go to a temporary LVAD, a temporary RVAD if the RV is the problem, or a BiVAD if both continue to be a problem. Okay, what if the heart and lungs remain a problem? Then you have to go to the same thing, LVAD, RVAD, or LVAD with an oxygenator. So you can add an oxygenator to your LVAD system, to your RVAD system. If you have BiVAD, then to the RVAD system. We don't like an oxygenator on the left side because of the increased stroke risk. Okay, if your LV remains a problem, but recovery is anticipated soon. Let's say you are on VA ECMO, you have revascularized the LAD, the heart is starting to recover, but it's not enough to decannulate. Then there are two schools in this scenario. There is the school who will implement an Impella at this time. So, or use the Impella that is already in as a vent and to provide some flow and decannulate ECMO. So you'll go, your ECMO is off, and you still have an Impella for the next couple of days that you need to reassess your heart. So you can, so if you are on ECMO Impella or ECMella, then you can remove ECMO, keep the Impella for the next couple of days. Some centers, though, prefer to use an apical vent that can be converted to a Centrimag LVAD. So if you are on ECMO with an apical vent, some centers will, from the get-go, put a large apical vent that can be used as an inflow for your Centrimag LVAD that's coming next. So then you transition from ECMO to at the bedside to a Centrimag LVAD using the apical vent as an inflow drainage cannula. I hope that is clear. I hope that's not too complicated. So there are two schools for this scenario. You're on VA ECMO, you're not recovering yet, you need a couple of days to a week or 2 weeks, then you can either go Impella or you can go Centrimag LVAD. Both can be done at the bedside. Okay, so I'm almost done. So just a couple of more slides on ECMella or ECPella. So center experience is key. Really, it's all about center experience for this talk. So with time, we've been moving from VA ECMO alone to VA ECMO with Impella together, and Impella is used as a vent and then can be used for partial flow when recovery starts. So ECMO can be decannulated before the Impella, to really the concept of ECPella or ECMella, where both are inserted simultaneously at the same time, because we know that the patient is going to need both. So and we're moving from the CP, which is usually done in the cath lab by interventional cardiology, to 5.5, which can provide much more flow, and it's inserted axillary. So the 5.5 can be done in OR. It can be done also in the cath lab, but it needs experience because it needs to be done through an axillary cannulation. So some centers, which has very high experience in Impella, had started to implement the ECMella protocol. Pretty much that, you remember when I talked about the device selection, the first group who are in extremis, who need full support because of biventricular dysfunction, who need oxygen support, and who need or have a high arrhythmia burden, should get through an axillary cannulation in OR with a graft, should get ECMO as well as Impella 5.5 at the same time. So then you use ECMO for your general flow and Impella for your vent until you decide if both can come out, or if ECMO can come out before the Impella, and then you use Impella for partial support, or if the patient doesn't do well, he passes away anyway. So some centers started to implement this, and it sounds like this is the way we're going for this scenario. Of course, if you had CPR, usually people won't do that because it needs time, and it's very manpower intensive, this protocol. So if you had any CPR, or then you go just VA ECMO, and then you add as needed. And if it's just a solo, if it's group 2, solo LV, SCAI-D, cath lab, acute myocardial infarction, then Impella is enough. You don't have to implement the Ecpella or the Ecmella protocol. So that's probably the future, and that's what some centers started to do. And by that, so what is the disadvantage of this protocol? You can see here that the complication rate, vascular complication, bleeding rate, hemolysis rate is much, much higher than any other therapy. So if you do Impella alone, or if you do ECMO alone, that has much lower risk of bleeding, limb ischemia, hemolysis, all of the above than if you do both. So it has higher complication rate, and that's why the center has to be experienced before they implement that protocol. And I would like to thank you so much and give it back to Dr. Weil.
What a great talk, Abbas. Really, you summarize it in, I'm personally, I learned a lot from this lecture. Very nice summary, and I like the approach, for versus devices. So we have tons of questions. We'll go in the few of time. We're gonna take some of them. First question: what is the difference between VAD and ECMO?
Yeah, that's a good question. So ECMO is a pump and an oxygenator, a lung and heart, where you drain blood from the right side, usually the right atrium, and you give blood back in the aorta. So you're bypassing the heart and lungs, both of them, and you support your patient with enough flow and with enough oxygen and carbon dioxide removal. So it is full support, bypassing the heart and lung. So when we say a VAD, a VAD is a pump alone. Okay, a VAD does not have oxygenator, although you can add an oxygenator, but a VAD, people think about it as pump alone, where it's implemented either to the left side alone, the right side alone, or you can do a pump on the right side, a pump on the left side, what we call BiVAD. Okay, so it's a pump only provided to a single side of the heart. That's a VAD. And the temporary is called Centrimag. The durable, it's called HeartMate 3. That's just the brand. But ECMO is a heart and lung that bypasses the heart and lung together. I hope that answers it.
Yeah, it's clear. Another question, what is your protocol for ventilator management in patient on veno-venous ECMO for ARDS?
Yeah, so this is a very good question. And I like to simplify it from the beginning that there is not much of a difference anymore between VA and VV ECMO. Both of them have to go on lung protective ventilation. So both of them have to have a low tidal volume. We say 4 to 6 cc per kg per breath, as well as a low driving pressure. It doesn't matter if you are on VV for ARDS or if you are on VA for cardiac support. Now, if you are on VV, the only challenge is sometimes with high VV ECMO flow, you still need to use the lungs a little bit for extra support because the lungs are the primary problem, right? So some people will do, for example, APRV to provide a little bit of oxygenation in the lungs, or will increase the PEEP and keep the FiO2 a little bit high. But there is no evidence yet for ultra protective lung ventilation. So some people are studying to go from lung protective ventilation, as I said, 4 to 6 cc per kg, to ultra protective lung ventilation, which you're just on a PEEP with a very little bit of a volume or even no volume to protect the lung the mass. Just keep it splinted, keep it open, but don't ventilate much. We don't have evidence yet, although a lot of centers do that.
There's an interesting question about the balance between during sepsis of vasoplegia and cardiodepression.
Yeah, that's a good question, and it combines the previous talk with this talk.
Yeah.
It's not about septic or cardiogenic as much as it's not about the cause as much as the pathophysiology. So I like more to say low cardiac output versus distributive shock. I like that more because it describes the pathophysiology, not the causative etiology. So if you have a septic shock with LV depression and low stroke volume, guess what? ECMO is useful in those cases. If you have, on the other hand, a cardiogenic shock, let's say it's an inferior MI, with hyperdynamic ventricle and a high stroke volume and low cardiac output, you may not be able to support that patient very well. So ECMO might not be effective. So it's about your stroke volume and cardiac output. ECMO is effective when you have a low cardiac output, low stroke volume for whatever cause of shock. I hope I made it clear because that usually provokes a lot of confusion for trainees.
A lot of learning point. I was really amazing talk, and let me also ask another question. In a patient with severe ARDS, sepsis, and septic shock, initially supported on VV ECMO for isolated respiratory failure and preserved cardiac function, what would be the recommended course of action if the patient subsequently develops septic cardiomyopathy characterized by a significant reduction in ejection fraction and organ failure, requiring renal failures, requiring CRRT, coagulopathy, and raising liver enzymes? This is a common scenario. This context of evolving multi-organ dysfunction will be changed to VA ECMO or LVAD.
Yeah, that sounds like a bad case that's going to die. Remember, if your patient is dying, there is that wisdom that you should have to know when to stop. Okay, you cannot keep going forever. So if your patient on VV is developing multi-organ failure due to septic shock or due to evolving cardiomyopathy or whatever, sometimes it's just the natural progression to death. Okay, so you have to know when to stop, and you have to say, okay, I cannot help that patient. Now, having said that, there are a few cases who develop RV dysfunction because of ARDS itself, or biventricular dysfunction in isolation of multi-organ failure. So first of all, you have to ask yourself, why is my heart going down? Why is the heart becoming a problem? Could it be an MI, for example? Is it a PE? Is it something reversible that you have to reverse? Don't just accept that it's just a multi-organ failure happening, the heart going down because of the progression of disease. So you have to think, why is that happening? Now, in few cases, we've went from VV to VAV. Okay, so what we do, we add percutaneously a femoral cannula, and then we Y the return venous with the arterial, and then we control how much goes systemic and how much goes to the RV for oxygenation. So that's called VAV, and that will provide some cardiac. So it will decrease the preload on the RV, okay, and LV. So that will provide cardiac and lung support until you figure it out. But again, don't do that to a dying patient, please. If your patient is going to multi-organ failure and is dying in front of you, don't add to the misery of the patient by providing more cannulas. But that can be done to a certain population.
Thank you, Dr. Aus, for these great answers. I think we covered a lot of questions. Some questions that we have still here in the panel and by the attendees are maybe out of the topic. So I think we might stop here. I just have one question because there is a lot of debate about when to use all these options. Actually, from a data point of view, does it improve the outcome of the patient? And you have seen, I think there was a Danger trial showing that, for example, we don't have any improvement even using ECMO or not using ECMO. So what is your take-home message from all this technique? Because we might say, some people say, no, there is no evidences. So how we can respond to them?
This is the best question, because this is a good for the conclusion of the talk. Okay, so we had 2 negative large ECMO trials, okay, followed by 1 positive Impella trial that was done over 10 years with a very strict selection criteria, okay, which is DANGER. All right. There is evidence that was done. If you take exactly the DANGER population, now that's post hoc, that's it's not a trial, but if you exactly, it's analysis retrospect. If you take the DANGER population and do ECMO for them, the exact population, you will have a positive results. And I can share that paper. It's a very intriguing, interesting paper. So in other words, if you select your patients very carefully, you're probably going to have positive outcomes, whether if it's Impella or ECMO. However, the selection has to be very clear. Now, what is exactly the selection? It probably would start by saying it's the DANGER trial selection. That's probably the best selection. But we haven't given up on ECMO. We think ECMO has a role. We think ECMO improves survival in certain cases. But what literature tells us is that we have to be very careful selecting our patients. So with time, we are narrowing really who gets MCS, not widening it. If you're widening it, you have to ask yourself why, with the literature showing you the results that you're talking about. But we're narrowing it. If a 30-year-old or a 35-year-old come with myocarditis, he's in SCI D, and he's gonna die if we don't do anything. Guess what? Most centers in the world will intervene and will put that guy on ECMO or Impella in certain scenarios. If it's, as I said, Impella, solo, LV, SCI D, you're in the cath lab, it's faster to go Impella, okay? And then flowing 3.5 liters might be enough. You don't need full crash support. So those patients should get Impella. And the other ones, extremis, oxygen, RV, arrhythmias, high flow should get ECMO. So don't forget that. I tried to simplify it in my talk, and that's the bottom line about the literature and MCS. Thank you, Dr. Ali.
Thank you, Dr. Aus. It's a very challenging, actually, topic because there's too many information and, of course, too many questions. And I would like as well maybe to emphasize that actually centers who are used to do that with a big team that know what they are doing, I don't think we need to improvise to do VECMO or Impella in such kind of patient. They should be trained and they get experience from centers who have done that for some time. So I would like to conclude now. I think it was a very great and interesting, informative session. We had more than 300 attendees, and really we are very happy to see the excitement about this program. We have two excellent speakers, Dr. Gordon and Dr. Aus for these two topics, and I would like to give you a rendezvous for the next topic, inshallah, and you will receive soon the invitation.
Thank you very much, and enjoy the rest of your night. Thank you, everybody. Thank you to our moderators and to our speakers. Please feel free to check our website, check the program, and thank you all. Appreciate it. Take care.
Thank you.
Bye-bye.